Welcome to our podcast, Making Clerkship Click, with your hosts, Tanmay, William, and Nick. If you're a medical student, this is a podcast just for you to get quick and easy primers on high-yield medicine topics that you're likely to come across when you go through your clerkship blocks. So let's dive right in.
All right, boys and girls, ladies and gentlemen, welcome to another episode of Making Clerkship Click. My name is William, I'm one of your hosts, and today I'm here to talk about another crazy high-yield topic relevant in everything from family medicine to emergency medicine to internal medicine, the bugs and drugs we deal with in pneumonia. Your choice of antibiotic is going to have big implications for whether your patient improves or ends up in the ICU, so it's genuinely a really important thing to think about. Now, I know all of you guys listening to this are crazy smart. I know that as you're listening to this podcast, you have Yale in your DMs, there's Harvard on FaceTime, everyone's begging you to join for residency. So I'm not going to insult your intelligence and dive deep in how to diagnose pneumonia. You all know it typically presents with fever, shortness of breath, and a cough predictive of sputum. You get a chest x-ray, usually see some sort of consolidation, airspace disease. At this point, though, your preceptor is going to turn to you and ask you how you want to treat your patient, and you have to give them some kind of answer. Your choice of antibiotic is going to depend on where the patient came from and their past medical history. Obviously, in real practice, you may have to adjust your choice of antibiotics depending on specific risk factors, like MRSA exposure, but this episode is going to cover the basics and give you a leg up on the wards. So let's start with your basic bread and butter cases, community-acquired pneumonia, or CAP. So, if the patient comes in from home with pneumonia, we need to cover common pneumonia-causing gram-positives and negatives, like Streptococcus pneumonia and Haemophilus influenza, as well as atypical bugs such as Legionella, chlamydia pneumonia, and mycoplasma pneumonia. If they're sick enough to get admitted to hospital, give them ceftriaxone, which will cover your typical bugs, as well as azithromycin, which will cover your atypicals. If they're well enough to go home, you can switch in amoxicillin for ceftriaxone, and a combination of amoxicillin and azithromycin will usually work just fine. If you're treating a patient who develops pneumonia after admission to hospital, well, our approach has to change a little bit, because now we have to treat hospital-acquired pneumonia, or HAP. The difference here is that in a hospital, all kinds of nasty bugs are lurking about, and we have to give something to cover everything from Staph aureus to Pseudomonas, which is a particularly troublesome gram-negative bacteria. This won't be covered by the ceftriaxone or azithromycin you'd use for a community-acquired pneumonia. So, a good choice of antibiotic here in the hospital is piperacillin tazobactam, or Piptazo, as the cool kids say. Which covers everything from Pseudomonas to methicillin-sensitive Staph aureus very, very well. If the patient develops pneumonia while being on a ventilator, though, you should be more willing to add vancomycin to Piptazo because your risk of dealing with methicillin-resistant Staph aureus is higher, and Piptazo alone won't be enough to cover that. Next, let's talk about another group of patients you'll come across. So patients with pneumonia who have risk factors for aspiration. They could have neurological issues like strokes, ALS, or MS, or a decreased level of consciousness due to alcohol, drugs, cardiac arrest, or trauma. Here, the patient is likely aspirating bacteria present in the oropharynx, so like the mouth and throat, as well as from the GI tract. And these bacteria are usually a mixture of anaerobic bacteria and gram-negative aerobic bacteria. So we have to find antibiotics that cover for anaerobes on top of our usual aerobes. This is especially true when you notice the patient has really poor dental hygiene or very, very bad breath, all of which are signs of anaerobic colonization. For these patients, you have a couple of options depending on where you are. If you're in the outpatient setting and the patient's well enough to go home, amoxicillin clavulanate, or again, amoxiclav as the cool kids say, is fantastic. If they're sick enough to come into hospital, but they're only moderately ill, you can use ampicillin sulbactam. If they're really, really sick though, you're going to have to go back to Piptazo. So all of these drugs, amoxiclav, ampicillin sulbactam, and Piptazo, have great anaerobe coverage, but our choice of drug is going to depend on how severe the clinical situation is. Finally, a fourth group of patients you're going to have to think about are those who are immunocompromised. So patients with AIDS or leukemia, those on chemotherapy. Here it can be tough to cover all the potential disease-causing organisms with antibiotics at the same time, because your culprit could either be bacterial, viral, or even fungal. So it's important to be aggressive with testing to find out which specific bug is causing the problem. Blood cultures, testing for viruses, even early bronchoscopy for a sample of alveolar fluid from the lungs are all really, really important. Perhaps the most important thing you can do here is consult infectious disease early and get them involved in management because they're the pros. So, to sum up, we've talked about a bunch of different things. CAP, community-acquired pneumonia. We're treating common gram-positive and gram-negatives here, as well as atypicals. So use ceftriaxone and amoxicillin for your typical bugs, alongside azithromycin for your atypical coverage. HAP, hospital-acquired pneumonia. We have to cover really broadly, from Staph aureus to Pseudomonas. So we give Piptazo. If the patient's on a ventilator, our risk of MRSA is higher, so add vancomycin to our Piptazo. Aspiration pneumonia. We worry about this in patients with neurological issues or decreased level of consciousness, as these patients are probably aspirating anaerobic bacteria. You can give amoxiclav if they're well enough to go home, ampicillin sulbactam if they're sick enough to be admitted but not severely ill, or Piptazo if they're really sick. Finally, PIH. It's tough to cover all possible bugs with antibiotics, so be aggressive with your cultures and testing and consider bronchoscopy. Call ID early. They're the pros here. All right, pneumonia, bugs, and drugs, hopefully all done in 5 minutes or just slightly over. I'll see you guys next time.